Good afternoon. I'm Cathy Bradley. I'm the Deputy Director of the University of Colorado Cancer Center and the Associate Dean for Research in the Colorado School of Public Health. And my topic is payment policy, how it affects digital health and its access. There are a couple key points that I plan to cover in the talk. First is that payment policies for digital health vary widely by payer, but have lagged relative to technology advancements. Initially, these policies aim to increase access in remote and underserved areas, but later incentivize cost reduction in healthcare delivery. COVID-19 accelerated use and revolutionized payment policies for digital health, at least for now, and future payment policies have the opportunity to be in sync with increasing both access and reducing cost. Prior to COVID-19, telehealth visits were motivated by rural communities and health professional shortage areas, but they were inconsistent and unclear reimbursement policies across states that limited its widespread adoption. Because Medicare, Medicaid, and private payers have differing regulations for reimbursement, it can be difficult for providers to create consistent use of telehealth in practice. Payment for a particular service can vary based on geography, payer, and setting. In absence of federal policy on reimbursement, it is left up to states to set reimbursement policies, and there are no two states alike. Several major pieces of legislation have influenced digital health reimbursement. 20 years ago, the Balanced Budget Act provided partial Medicare reimbursement for live video digital health, where practitioners are required to be with patients who were accompanied by another practitioner at the distant site. Both practitioners split the reimbursement. Cumbersome, to say the least. The Benefits Improvement and Protection Act removed prior restraints to telehealth, such as the need for a telepresenter. However, geographic locations, originating sites, and eligible services limitations remained. The Health Information Technology for Economic and Clinical Health Act motivated the implementation of electronic health records and provided incentives for physicians and hospitals if they could show meaningful use of electronic data, then paving the way for more widespread use of digital health. And the Affordable Care Act enabled the Centers for Medicare Innovation to include technology in the development of care models and expanded the type of telehealth consultations reimbursed. In 2015, the Medicare Access and Chip Reauthorization Act accelerated the shift from traditional fee-for-service payment models to alternative payment models with higher payouts for practices that show improvements in quality and reduce cost. Telehealth policy at that point evolved from increasing access as the main objective to also a way to decrease cost. The Bipartisan Budget Act further expanded telehealth, particularly for ACO beneficiaries. And last, the 2019 Physician Fee Schedule allowed reimbursement for check-ins and store and forward, where providers could provide patient information collected remotely for reimbursement. The analogy I show here is one of a kayaker going over a rapid stream, and that's the digital health information technology and innovation that has occurred. Meanwhile, payment policy legislation has lagged in taking a much more calmer or more steady approach rather than keeping up with the digital health explosion. Let's consider the impact of these payment policies, the major legislations I just presented, on specific payers. Prior to 2019, Medicare payment policies were most restrictive. Patients must be eligible through an originating site for provider reimbursement, meaning that they could not have telehealth visits in their home. This restriction was relaxed for some digital health services provided through the chronic care payment codes, but oncology was not included. Medicaid approaches to payment has been fragmented. All 50 states and the District of Columbia reimburse for some types of live video telehealth services, but only 16 states Medicaid programs reimburse for store and forward services. 23 states reimburse for remote patient monitoring, but with restrictions. For example, restricting clinical conditions for which symptoms can be monitored or limiting the type of equipment that can be used for monitoring. Only Missouri and Texas mention cancer as a condition in which remote patient monitoring is billable if determined to be cost-effective and feasible. 43 states reimburse a transmission facilities fee or both, and 19 states allow for the home to be the eligible site for certain circumstances. Private payers have evolved faster on their reimbursement policies. Federal laws do not require private payers to reimburse for digital health services. It is left to the states to decide. And 42 states and DC have private payer parity laws, meaning that telehealth visits are reimbursed at the same level as an in-person visit, and 10 states have true parity payment. And you can see from this graph that there's been a huge change in just the past 8 years. In 2019, or in 2020, COVID-19 revolutionized payment policy. There was a large increase in digital health utilization, over 600% increase. The CMS waiver allowed Medicare, Medicaid, and CHIP providers to conduct digital health, expanded this provision to new and established patients, allowed billing across state lines, and expanded the geography well beyond rural health areas. Services were expanded and sites were allowed to use consumer audio and video technologies, FaceTime and Zoom, to conduct digital health visits, decreasing a barrier on both provider and patient side of comfort level with technology. And many private insurers eliminated copays or costs associated with telehealth altogether. Flexible payment policies due to COVID are set to expire, however, after the pandemic. Post-COVID payment policies accelerated the use of telehealth, reducing barriers for all patients. The benefit may be greatest for those in severely compromised health because they don't have to go out of their home for these types of visits. And it opened a way for widespread use and future expansion and socialized the idea of specialty care and became more acceptable for oncology care to be conducted digitally. However, not all providers were able to rapidly adapt. Participation in a network or system provides greater opportunities for adoption for telehealth. Typically, these networks have greater technological capabilities, and technologies are often shared across sites, increasing access. Major teaching hospitals often have more state-of-the-art care, and hospitals with bundled payments are 2 times more likely to participate in telehealth than those who do not. And this is a perfect example where payment policies truly do influence the use of digital health. On the other hand, public and government-owned hospitals, about 20% of all hospitals, who primarily serve low-income, underinsured, or uninsured patients, often provide urgent or emergency care and more likely to supply unprofitable services that are disproportionately needed by low-income patients, are less likely to adopt digital health. And at the other end of the spectrum, for-profit hospitals, those that serve affluent and insured patients and provide elective procedures, are also more likely to adopt digital health programs. And requiring out-of-state providers to have a special license means more barriers to serving patients. Now that we're here in a post-COVID state, what can payment policies do to incentivize or curb telehealth use? First, I want to start with a couple of caveats. We're new to this phase, and there's a lack of evidence base and a need for more research, especially on quality of care, outcomes, and cost effectiveness of our recent and rapid shift to telehealth. There's policy gaps that remain, nonetheless, that can be addressed. There's confusion of which services are covered and how much providers will be reimbursed, and there's different reimbursement or covered services from different payers. Some payers are worried about overuse of telehealth. Some states reimburse for remote monitoring while others do not, and only 2 states include teleoncology as a remote monitoring condition. There's an opportunity now to create consistency and remove confusion in covered services and providers reimbursed. Also an opportunity to increase access by allowing home visits. And if our goal is to put telehealth infrastructure in place and remove restrictions for providers to practice across states and incentivize through alternative payment models and payments for adoption. The time seems to be now to be able to put those in place permanently for patients. And ultimately, our goal is to reach more of a state like this, where the rapid innovation can meet a calmer water that is consistent with where the technology is today and provide payment policies that are appropriate for the state of the art. Thank you, and I welcome any questions.